Mower also. Cookie, you're welcome to join.
Thank you, sir. I appreciate it. I'm glad to be here.
And I want to thank Janice and Kim for working on the back end and sending all the invitations and giving us a critical mass of people to participate. So we're really grateful for that. And Dr. Lilaram, welcome. Charlene Jones, welcome. To get us started, I wanted to acknowledge that it takes a group of people to get these lunch and learns scheduled, and that it is time in your behalf also to participate. So we try to have some topics that are interesting and relevant. And also, sometimes we schedule these and I can't participate. So I want to thank Dr. Chang and Dr. Moran for hosting sometimes at last minute if I get pulled away. I really appreciate everybody joining us. So we're going to start getting started because we're about to have 50 participants. So welcome to our first Lunch and Learn for the year. I'm Roberto de la Cruz, your Chief Clinical Officer, and this is hosted by Medical Affairs, but open to everybody. We usually have a mix of clinicians and non-clinician professionals. So it's a really varied audience. We bring topics that are relevant for everybody. This topic today, I have a great curiosity about. I have the research office under my organization, and for the last few years, I've been having the question mark. You know, we have all this great research that is produced at Parkland and developed at Parkland, but are we benefiting, are our patients benefiting from the outcome of that research? And I scratch my bald head and I try to figure out what are the limitations for that. And I realized that I need to get some education myself as to implementation, its limits, how do we align better, you know, when we have research projects, and there's a science to implementation. So it's called implementation science. And I'm really grateful to Dr. Jackson, who's a professor at the O'Donnell School of Public Health in our adjacent campus at UT Southwestern. And he is leading actually the area of the School of Public Health that deals with implementation science. I want to remind everybody the rules of the game. Please set your phones down and pay full attention to the presenter, and let's give him the respect that he deserves. Please generate some really great questions, and you can put them in the chat. You can put some reaction in the chat. I can moderate them at the end of his presentation, and also I can ask you, to unmute yourself if you want to go ahead and ask questions in the end. So first of all, thank you so much. We have over 50, as I predicted. Dr. Jackson, you are welcome to take over our next hour of learning. Thank you so much.
Thank you so much. I'm going to go ahead and share my screen here. And it was working. Let's see where it went. Hold on 1 second. So it's not letting, now it's letting me share. Sorry about that.
Yep, we can see it now.
Okay, perfect. One thing about implementation science is you have to be a bit ready to address the unexpected, and that includes our technology here. Can you all hear me okay?
Yes, sir. All good.
Perfect. So my name is George Jackson. I came to Dallas about 6 months ago to join the new O'Donnell School of Public Health at UT Southwestern. Coming from North Carolina, I was at Duke for a long time, and I also have a hat in the VA, still in Durham, but also over at the Dallas VA. And I do sort of, my area of research is team-based care. So I've heard a folks in the nurse practitioner leadership are on. I've done a lot of work in what are the roles of and how do we have most effective teams with nurse practitioners, PAs, and physicians, for example. And I also have a MHA. And today I want to talk a bit about implementation science. Let's see if we can get it. There we go. Sort of what is implementation science? Sort of why do we care? Giving a few examples, and really one of the big goals of today is to sort of continue the dialogue that has been started by a number of folks, including our Dean, Saad Omar, around how, what are ways in which the School of Public Health in Parkland can best partner to go across the research and quality improvement continuums to help you all in the work that you do. So I'm really excited to be here today. So we can get it to move here. First, why are we interested in implementation science in the first place? And Dr. Chris sort of laid this out well. Typically we hope that we're going to have an idea for a problem and we're going to have this brilliant solution and we're going to pilot it and do a bunch of clinical trials and in different places, and people are just going to read our articles and go out and change the way they do work. Well, of course, we know that's not the case, and we know it frankly will never be the case. One of many reasons is the silos that we work in, where research and quality improvement will have offices, clinical care, population health, all the way through folks like me who have a background in administration, and then those who are constituencies outside, are including our communities and public health partners. The goal is to say, how can we reduce these silos and really think about moving care from what we know to what we do. One of the terms that's become used more and more lately is the learning health system. And Parkland, I've had a chance to get to know a number of you at Parkland, really is a leader in this space. The goal of utilizing expertise and data to develop, implement, and evaluate innovations to improve quality of care. So we all are on a mission. You all have got a mission. We come from the VA for a lot of our work where there's a clear mission of improving the lives of the people that we serve. So the goal is to align science, clinical, and organizational priorities to do that to really take a population perspective. And so our goal is really to be a team. That's why that first slide says change is hard, but we can do it. We can do it as a team. In order to do this, though, we really need to think of things as a system. We recognize that there's policy and an environment outside of our organizations that impacts what we do, a system for delivery, important evidence-based practice that comes from things like clinical research, or being aware of the social determinants of health of those we serve, our care delivery processes, and where we're really going to talk today about the science of healthcare delivery. Implementation, how do we go about doing this so that we can think about this as an interrelated system to enhance healthcare delivery, as well as considering the well-being of not only our patients, but communities and the people who serve them, so the people within our organization. This could also be because of why are partnerships between health and service providers and schools of public health important to this learning health system? So why, as you're thinking, would you say, well, maybe we should partner with the School of Public Health to think about how we can enhance care? Well, what is this thing, implementation science? It is, it's become sort of a term we're hearing more and more in healthcare, and there is a science behind how we take sort of what we know and move to where we're going. So one of my favorite examples, and I think one of the more obvious ones, is hand washing. So we've known for well over 100 years that washing the hands in a healthcare setting is important for infection control. But the reality is less than 50% of people working in healthcare systems actually wash their hands on a regular basis. And it's well known that physicians have lower adherence rates than others. So we know the science tells us where we need to go, but the reality is we don't do this. And I've had some friends who have been run healthcare quality improvement for large health systems, and they talk about they'll do a hand washing campaign, and 3 years later they're finding they need to do it again. So it's a constant challenge. So implementation science is supposed to help us say, how do we help actually put those practices into what we do every day? So it is a scientific study. So we're looking at the methods. It's also termed the strategies to promote the systematic uptake of research findings and other evidence-based or evidence-informed practices into routine practice, into what we do every day. And it involves understanding innovations, or sort of what do we want to implement, the organization in which we're implementing it. So what are the barriers and facilitators at that organizational level? And then the fact that all organizations are made up of people, and we have to change our own way of doing daily work to make this happen. So at the core of it, it's the science behind that. This is a picture that I really like that I think helps to demonstrate this. Many of you will recognize this is a picture of the Hoover Dam, and one of the things when you go to visit the Hoover Dam, you've got to get over the Colorado River, over this gulf from where are we starting? So in our case in healthcare, what do we know? Over to what do we do? And what we know can come from science, but I also don't want to discount our everyday observations. So I'm certainly, as researchers, I certainly think research is very important, but I also think what we see on the ground is very important in terms of what we know and what we want to actually do. So for those of you who do quality improvement, it's our present state to our future state. But in this picture, you'll see there are multiple ways of getting over the Colorado River. There was the way that had been there for 100 years, sort of a windy road that goes over the dam and sort of winds back up the mountains. It was recognized a little over a decade and a half ago, though, that there is one. It takes a long time, and there's some barriers. So there's security barriers. They had to inspect all the cars going over the dam and sort of in the post 9/11 era. So they built a new bridge, a bridge that's straight and fast. So though with implementation science, you could think of as comparing what are those strategies for getting over the river, or what are those strategies for moving from what we know to what we do. There's some big components to an implementation science question, and really these are components to all of our efforts to enhance our health systems, where, well, going back to our hand washing example, we have an innovation or an intervention. So we know that our goal is to wash your hands more in the healthcare setting. Then there's strategies, ways to do that. And one of my favorite studies came out about 20 years ago out of a hospital in Chicago, where they realized that attendings washing their hands when everybody's walking into the room on rounds gets, so it's not surprising, everybody else to wash their hands. So that leader of the round saying, this is important. And then we want to look at, well, what are the outcomes of that? And there's two kinds of outcomes. There's an implementation outcome, or are people washing their hands more? And then there's an outcome of that intervention, of doing that, which we hope are fewer infections. So this sort of demonstrates just sort of, and this basic question goes along all of these sorts of things. What do you start with? What's your intervention? What's your strategy? And did you actually do it and get better care? This sort of tells you a little bit more about this thing, the implementation strategy. This is one of the sort of jargon terms that's out there. But it really are the techniques used to enhance adoption, or in other words, do we make the decision to do something, implementation, and sustainability of clinical, administrative, community, or public health programs or practices. So it's the ways, it's those bridges. Which of those works better to sort of get across to doing everyday work? And the goal is to take those findings and put them into practice. So back to our hand washing example, this was a review of some of the strategies around this. some that are necessary but probably not sufficient. We do need basic knowledge and awareness and cues to wash our hands. And that goes across everything. The challenge becomes what additional things might be necessary. Leadership indicating its importance, the social influence, the attendings example that we mentioned, and sort of setting norms around that place. And training. So you say, well, this is easy, but we would think then that everybody would do it, but we don't see that, of course. So our goal here is to help understand what's that combination do we need to do in different settings to get forward, and also then taking a really deep dive into understanding what is it about the innovation that's better. What is the advantage, for instance, over what we do now? What are the incentives in the organization and the sort of rules and regulations that may impact our ability to implement things? And then the people. So knowledge, beliefs, goals about the advantage, and sort of how can we fit this into the work that we as individuals do every day? Because again, from what we know to what we do takes going and considering all of these things. So implementation science helps to figure that out. I'll say one thing that's sort of beyond the scope of what we're talking about today, but just to go back to the notion that there is definitely a deep scientific base to this. So there are theories and frameworks that go for each of these groups to sort of say, how are we doing it? And one of the things we can do in the School of Public Health is help think about what are sort of these broad theories tell us about what are the everyday actions that we would take. So for those of you who might be on the research side and want to write grants in this space, we can help with that. For those of you who are interested in partnering on improving the services in your area, we can sort of take what do these things tell us and sort of translate those into things you might consider doing. And ultimately, the goal of implementation science, working through the wide range of other public health and healthcare sciences, is really to say, how can we enhance system improvement? And whether that's user-centered design, which is simply working with people who are going to actually use an innovation or an intervention to make sure it's something that is practical and reasonable, to the implementation practice of actually doing the hard work of taking those say research findings and moving them into practice. We hope to inform quality improvement, so the systematic improvement of care to have consistently achieved high outcomes, as well as one thing that we do a lot of, which is program evaluation. So in the work we do, I'll give you an example. We want to know, so what were those barriers and facilitators of implementation, along with so what were the outcomes? So the goal is we want to be part of the mission, just as all of you have pieces of the mission to enhance the quality and consistently providing high-quality patient-centered care. So I think the key of this is that this is a very applied area, and where some of those partnerships can be is in that system improvement space. And please yell out if you have any questions. I'm happy to answer as we're going along. I can't see the chat, unfortunately, as I'm going through this. So I want to talk about a couple of examples. One is focused on building the system. One of the things that you all have such a great system around innovation at Parkland, sort of really taking what are these frontline, what do you see on the front line as needs, developing those innovations, and then doing the evaluation research to say, well, what happened? Well, let's talk first about an example where we've looked at this in the VA, and I think we're learning already a lot from what's going on in Parkland in this space. And then I'll show an example of a very specific project where we used implementation science to sort of move this forward. So the first, focusing on the way in which we set up the system for learning health systems. And an example is the Diffusion of Excellence program within the Veterans Health Administration, where it was recognized, it was in about 2015, that while the average quality of care scores across the VA healthcare system met or exceeded that of the private sector on most things, there was important variations that shouldn't be there between one place and another. And if my VA is not providing that highest level of care, it's great that others are, but I want to make sure that we get this same sort of consistency across the whole system. So the Diffusion of Excellence was set up to identify innovations that were effective in the system. A VA Shark Tank competition I'll mention in a minute as an example. Facilitate replication in new sites, and then have pathways to diffuse across the whole system. And so they have specific staff support for this, institutionalized processes, training opportunities for innovators who have that idea and want to move it forward, information technology for tracking innovations, and where we've come in is an independent program evaluation. So they want to work with researchers as well. To give you an idea of the implementation strategy, which is the VA Shark Tank. So, the goal is for frontline VA employees who have developed an innovation and shown that it's been effective in at least one medical center or location, and hopefully more, apply to this Shark Tank. So they submit an application. Those are evaluated by subject matter experts. About 20 finalists then present the practice to sharks, and those are hospital and clinic leaders who then bid resources to help replicate that, and in their site. And those winning bids determine promising practices. And the reason that the medical centers and sites do this is they see that there's a chance to say this thing that works somewhere else might work in our site, and we want to make sure we have the resources in place to do that. They then get 6 to 9 months of facilitated implementation. So they are called implementing fellow sites, the new sites that are doing this work. They go to an in-person base camp where they start planning implementation. Then there's facilitation for each site. So there are people who are experts not only in the intervention itself, the people that started it, but also in the ways you do quality improvement and implementation work. And then this last, and the hope is that one of three things happens. Either there's national diffusion with the help of staff. You could think of that as if you tried something in one clinic, you might diffuse it across all of your clinics, say at Parkland. The teams receive specific additional training on what does it take to do innovation. And the final ones, things that are promising but not as promising, are packaged and they hopefully go out for organic diffusion. Here's an example, and this is one that was, I will say, was actually developed by my VA boss, and I've been involved a little bit over the years in this, and that's called STRIDE, or Assisted Early Mobility for Hospitalized Older Veterans. So it's recognizing that there's a need to prevent functional deterioration among people admitted to the hospital and get folks up walking as early as possible. So the supervised walking program was developed, and STRIDE showed that it increased the likelihood of discharge to home. Patients stayed one day less in the hospital, and they reported feeling better after the walk. So this initial work that's been published here is now, it's been now in 65 hospitals across the country, and people are doing this. And the nice piece is we've been able to continue to do research on this. So it continues to show a benefit no matter where we're putting it out. And so that's the goal. So it's just one example of these pieces. Well, where do we come in as implementation scientists? it was recognized early on that we needed not only to understand what's the impact of a given practice, did you reduce length of stay, for example, but we're setting up this entire system in the VA. So there was a desire to say, understand things like how do we encourage meaningful engagement among people at all levels within the organization in diffusion of excellence. Understand how leaders choose practices to implement. We're coming at you as leaders in healthcare systems all the time to say, we want to do this or we want to do that. Well, how do you make that choice at the end of the day? What influences implementation success once it's there? And then what influences spread and sustainment of the practices to new places? So we've been able to do this with a combination of quantitative and qualitative methods. We've used those frameworks that I mentioned earlier as a way to sort of base this in the science that we have. And I'm going to talk about it in one of the sort of well-known or sort of broader used frameworks in implementation where there's a way to lay out the kinds of outcomes we get, the reach of our practices, how effective it was, whether people actually adopted it, what does it take to implement it, and then can we maintain it over time? So give you a quick example of what we've seen here. I'll just say on this, this is a large project that's been ongoing since about 2017. So we've used administrative data and information on the implementation process and spread of implementation to understand trajectories of innovations. We've done a lot of qualitative interviews, and the School of Public Health here has got a great qualitative group that they can help design that kind of work. Observations and focus groups of events, and then surveys of participants at all levels within the organization to understand both their roles and whether practices are sustained. So this really is sort of bringing together the variety of things that we do in implementation science. Just to give you a little idea, this is data through 2022. We're finishing up analysis of data through 2023 now. Across the first 8 Shark Tanks, there were, and this was across the country, there were about 3,300 applications and about 88 things that were made into VA promising practices. About 140 to 141 sort of parent VA health systems participated in terms of sending things in, so that's really exciting. And about 60% of these systems participated as sharks. So there's been pretty wide reach of this program. When we look at effectiveness, there are really 2 things. As I mentioned, here we're looking at the effectiveness of the system as a whole. Is this innovation system, what are we getting for this versus other things we could do? There are other groups that are looking at the implementation and effectiveness of individual practices, and I'll show an example of what we've done. So again, these practices have been fully or partially implemented as of sort of beginning of 2023, 1,400 times or so, 13 national diffusion practices or practices that have gotten staff help to go across to new organizations, have been implemented about 966 times and impacted almost a million veterans over that time. We move on to adoption, or sort of what were the decision-making around actually starting the innovation and all of these health systems saying, okay, we're going to actually do this thing. One of the things that we've noticed is that individuals develop practices because they're most often responding to things they see when they're in their clinic, when they're doing the administrative work that they have to do. In other words, when they're saying, what is my role in the mission of enhancing the health of the people that we serve? So one of the challenges is taking that passion project and helping facilities make decisions about doing this work, and including the sort of things that the CEO or the chief medical officer in an organization has to think about broadly and consider those things and try to match that with what's going on the ground. And the same things happen to very senior leaders. So you can think of this as sort of your C-suite healthcare administrators. Think about these same things, but also how are you going to sustain this thing in the long run? So we sat and we developed tools to help do this. So both people that have developed the innovation, listing out what do they really need at that organization to replicate it, both what's the minimum and what do they wish they had. And then this sort of consumer reports looking report that we have to also help the organizations compare major components, like how long is it going to take to implement this? What are the resources that are going to be necessary to do this? And so to do this tool, and it was able to sort of enhance that decision-making through the sharp bidding process. And I'll just say that this same sort of work is being used by folks who have developed this idea. Tom Houston, who's now at Wake Forest and Atrium Health, they're using the same sort of thing to help leaders in the organization sort of think about, well, what are the major initiatives that they want for upcoming years? And more broadly in the VA, they're doing the same general idea as well. So we're able to make a difference. But then we have to think about implementation. So the connections between those people who had that passion project and then getting it into the organization. And we saw that we were seeing two different kinds of things. Sometimes the leaders of the organization said, we are going to do this. And they're pushing it into the organization without really talking to people on the front lines, and they're often then experiencing more barriers to implementation because, for example, well, the leaders may say, this is something we need. We see this in our quality reports, for example. And the folks on the front line say, well, that's really not the thing that's driving, the challenges that we're facing. So they get worried. And as opposed to pulling this in, as opposed to the leaders working with the other managers in the organization who can work with the front line to really say, I really want this in my organization. They have fewer barriers. The other thing we've learned is not to initially give up on implementation. So we found that initially about half of practices sort of in the early days successfully replicated in 6 to 9 months. And as things have gotten better and better, that's improved. But many of those practices are able to go on with a little extra time to actually be implemented. And about half of these practices are continue to be implemented, 2, 3, 4 years out. And of those who do it, about a fourth of those that stayed in business weren't getting there by the 6 to 9 months. And so the message here is trying to really be flexible when we set a new project of what do we need, what are our milestones to say we're going to continue to try to implement that. And finally, maintenance. So about 56 of the 88 practices are still being sort of monitored by the VA. Some that aren't, it may be that technology has sort of taken up the need or some other new program, but they were still very successful. And over half of them are still sort of going from those early start things. I'll show you all may want to look at this diffusion marketplace, which is a way that we put out, and this is a public-facing site, put out a lot of these innovations that have been tried in the VA. There's information about who to contact, you can search on different clinical or administrative challenges, and it both allows us to sort of monitor their implementation, but also put out broadly and publicly, here are things you may consider to address challenges in your health system. So in conclusion around this, the nice thing for us is that people have been able to take what we've said and make use of it. So sharks need details. So we ended up with a quick view and wish list. We need to clarify individual roles of everybody in diffusion of excellence. So having additional training and earlier interaction with folks. We need to be able to align needs, resources, and leadership support. So that led to sort of participant agreements when they said, we're going to actually implement this. What are we going to, you've got to sign this, say this is what we're going to do. We noted persistence matters. So proactively planning for transitions as you move out of that facilitated replication. Over half of practices have been sustained at those early replicating sites, and so there are new programs to sort of begin planning for sustainability early in the process. And finally, a recognition to track innovations across the system. I showed this slide about embeddedness because we're a highly embedded, we sort of walk along with diffusion of excellence. We're really embedded within the system. And I mentioned that just to show that we can often be just highly partnered with you all on the operations side to do this. We also go in and do other evaluations that are sort of drop in. Here's the evaluation that we need. But as you're thinking about partnering, it can be on both sides of this process. And this just shows a team. This is very much implementation science, just like quality improvement and other system improvement is very much a team sport. The other example that I want to mention is one that is more specific. So we have the system, so we can help you look at the system. We'd also help you look at individual practices. So I'm going to talk about some work that we've done around enhancing the quality of provider practices for older adults in emergency departments. Recognizing that there are, over 22 million ED visits a year to emergency departments among those age 65 and older. But the majority are not admitted to the hospital. So they're often sent home on medications, and it's about over half the time at discharge. So they may have new medications, and some of those may or may not be appropriate for older patients. The American Geriatric Society's Beers criteria that many of you may be familiar with was developed by Mark Beers in 1991 as a way to say, you may need to stay away from these medications. For example, if you have an 85-year-old person coming in with back pain, you may want to consider whether a muscle relaxant that may make them less stable would be appropriate. So we use this in a clip to define potentially inappropriate medications and to sort of say, okay, here's a clinical guideline for providers to consider. There's certainly going to be times when it's appropriate to prescribe some of these medications, or there may be no other choice. But this is something for you to really consider to try to reduce those potentially inappropriate medications. So here's how we looked at using an implementation strategy in a project that was developed by our colleagues Camille Vaughn and Melissa Stevens at the Atlanta VA and Emory. So there's a need to identify the problems that need to be addressed. So we talk about early prescribing, inappropriate prescribing medications in the ED. Identifying an intervention or a guideline. So the Beers list is an example. Determining and measuring quality, or in our case, the percent of prescriptions that are potentially inappropriate. Developing a strategy, and we'll talk more about this in a minute, that takes those implementation strategies, or audit and feedback, in our case, and clinical decision support, and then asking, did the measure improve? So it goes like it's an example of one of those questions that we mentioned earlier. So again, I mentioned that this was developed by Camille and Melissa, originally funded as part of quality improvement. It didn't come out of research. But there's a goal to have the strategies to implement the Beers criteria. So those strategies included provider education, audit and feedback with credible measures of quality, regularly delivered feedback, achievable performance goals. So we're not asking people to do things they can't. We're not asking people to say there'll never be a potentially inappropriate medication. And initially, academic detailing. So the goal is then to link that audit and feedback back to order set tools in the electronic health record. So it's been currently implemented in 20 VAs and 5 non-VA sites, several with sort of multiple EDs, including the sites that have Epic as the platform. And I got involved in this early on because we were working on this at the Durham VA. We were helping them out and thinking about how do we actually implement it. Well, in that quality improvement recruitment work, there were substantial reductions at these 4 initial sites in the percentage of patients with potentially inappropriate prescribing. And so that was a great thing. And we saw that this has been published, or some of our work in Durham has been published. But we then realized that there was a potential need to bring research into this. Academic detailing can be quite intensive. So it's one-on-one with a clinical expert and a clinician seeking to change their behavior. It's targeting messages to the individual clinician, including discussion of specific cases, and it can take a while to sort of focus on, how do we eliminate the barriers to doing the care the way that these clinicians really want to do this. So we recognized, started to ask the question, is that the best way to provide feedback? Feedback was provided initially with individual sort of piece of paper that went to folks, and then later we were able to develop dashboards that included looking at the percentage of PIMS written by class, a drill down to individual patients if you really wanted to look at the information, and also peer benchmarking. Where are you compared to your peers? And if you had a PIM in a given time, there's a new screen you could sort of dig down into that, and it would give you potentially what are some alternatives, what's other information that's there. We then wanted to test sort of is that active feedback from academic detailing more effective than this dashboard. The dashboard is pretty advanced. It takes into account similar principles, but it doesn't have that sort of, your trusted peer going to you and saying, here's some things that could be done. So we got a funded trial. I was fortunate enough to be the co-PI with Camille on this, and we wanted to understand that implementation. This sort of just gives you an idea of the sites that ran between 18,000 and 40,000 emergency department visits a year. We did this. These are sort of some of the implementations. These are like the implementation sites that actually went in and implemented this. But you got a variety of different of sort of sizes of ED. What were the outcomes? When we were able to sort of compare what was going on in the 6 months before, what was happening during implementation, and then post-implementation, the academic detailing group were improved about a percentage point. And this was sort of across every prescription written during the time period at these EDs. The group that was sort of dashboard group got a slightly worse. There's really no difference between the two. So when we look at this tradition, we say, well, this was a successful innovation. But we really want to dig deeper into this. This was at the facility level, not at the individual provider level. We want to understand, and there is very important variation here. So we want to understand what is that variation. Oh, sorry, we're back. So we really wanted to think about those implementation considerations. This was set up during COVID. We literally were about to we were talking to people in March. COVID hit, and we thought we weren't going to be able to do this. And only one of the sites ended up pulling out, and we had to get a new site. But it ended up the places were able to do it. But there was variation in site champion role, for instance, geriatrics versus emergency departments. The role of the pharmacy varied, with some EDs having specific pharmacists, others not, so that became a big part of their process. The feedback varied, right, in the exact way they did it. This was implementation. We weren't telling them how. We gave them guidelines. But we were able to see that they could put this in place. They could make those order sets. We weren't comparing order sets, but they were able to put them in place. But the reality is, at baseline, the site champion determined who would actually receive the feedback. They generally stuck with staff providers, sort of full-time staff providers, as opposed to moonlighters and residents. So, about 15% of people actually got the feedback. Now, these are folks that accounted for 60% of the prescriptions. So from the point of view of those folks, this was a good idea. But we're really getting into the fact that among those people who got the feedback, there was a greater reduction in PIMS rates and potentially inappropriate medication. It wasn't different between ours, and that's leading us to the next piece of how can we both enhance utilization of the feedback, but also maybe if we can enhance utilization, maybe we can dig more into the dashboard. So that just gives you an idea. Again, this is a team sport, and I want to recognize the team. In the last couple of minutes, and if anybody has any questions, again, please stop me. I want to sort of mention the School of Public Health. Some of you are more familiar than others with this. We started officially in the summer of, we started officially with the summer of 2022, and this is a team that's growing. Our dean, Sadover, is here in the middle of the picture, and the reason one of the things I think he's really said to us is our goal is excellence for impact. The reason most of us came here, if all of us came here, most of us in this picture are new. Not everybody. There's some folks you'll recognize that have been here a long time, but is to work with groups like you all, to work with our partners to say, how can we do high quality research? How can we do high quality implementation and improvement work? But again, help to enhance the health of the people of North Texas and beyond. You'll see the webpage that's there. I'll quickly mention there's some education programs for folks that are really interested in learning more about public health, and MPH, an MD-MPH program, and a PhD program. We're also starting certificate programs that we anticipate will start in the fall, including geographic information systems, public health, sort of fundamental, sort of the base courses to sort of get an idea around public health. And one that we're starting on our program, quality improvement. So folks that are interested in how do we take all that stuff we talked about in implementation and actually think about what does it mean for quality improvement purposes. So those will be starting, and you can see more on the webpage. We also have a bunch of different research programs going on, data and precision health, our program, advancing implementation and improvement in science, a vaccine program led by Saad, a new program that we're recruiting the director for around pediatric population health and population science and cancer control. And many of you know Celeste Skinner, who was our interim dean, and who sort of got us started and then is still with the cancer research. This gives you an idea of what sort of programs are already under development, and we've got cores and things like qualitative research and statistics as well. Our program in implementation science, again, is seeking to enhance collaboration, developing systems to move potentially successful projects into the everyday work that we do, as well as helping things think about what are potential funding sources for this kind of work. And then if you're applying for grants or if you're developing new programs, what are some of the methods that you may see? And and people can always contact me or our program manager, Giselle Martin, who does a lot of great community work as well. I just want to say, I think this is building as we finish on a long history between people in the School of Public Health and Parkland that has been, for instance, the work you all have done in understanding cancer screening, work that's ongoing around palliative care and cancer care quality, food as medicine, work around child care and made that available to patients. There's just a wide thing, and we're excited to be working with innovations at Parkland and with many others, and that's that's sort of all I have. If there's any questions, here's some information on how to get in touch with us.
Thank you so much, Dr. Jackson. I learned a lot, and it was a really good talk. Thank you for starting with hand washing and capturing our attention, and then sort of moving towards some really interesting innovations that were able to be developed at the VA. And I really appreciate that we can go in there and search and find evidence-based practices and then implement them. The audience here is really interesting, very nursing heavy, and one of our leaders in the orthopedic nursing department was here, and I'm sure that they know about early mobility for their patients, but this is pertaining all patients, regardless if you're an orthopedic patient, which to me is really interesting. Dr. Durso asked a question about policy, and so it's a policy question, like what's the role of the legislative or local authorities in funding support for implementation science? Like, where is that right now? Is it still in development, or are there ample sources of funding?
So in terms of our work here at Southwestern, we were able to utilize some of the funds that came from the O'Donnell Foundation to help start the school to sort of build out the systems. So we're hiring faculty. In fact, if anybody knows of anybody that's interested in the space around the country, we're actively hiring and recruiting. But so some of that work is case. We will all certainly be going after grants, both research grants as well as operation grants. And the other piece that we've learned from some of the work in the VA, and again, I know Parkland is done a lot of great work in this space, is certainly it does take an infrastructure in the health system to be able to have staff dedicated to help frontline staff, for instance, do innovation work, to be able to address the mechanics of research and do that sort of thing. So I hope that helps with sort of where we're sitting.
Okay, but the point is that there are federal agencies and others that are interested in funding this type of work.
Yes, and sorry, I can't see the chat. No, it's okay. Actually, so there are specific, for those of you who do research, there are specific NIH program announcements around implementation science, as well as interests, as well as interest at the NIH and some of the other institutes, PCORI, Patient-Centered Outcomes Research Institute, Agency for Healthcare Research and Quality, Department of Defense. There are a number of different groups interested in this, as well as partnering with the VA. I think there's a lot of overlap in mission, for example, between Parkland and the VA.
In your slide that had the building blocks for innovation, in the center you had systems-based thinking, which is something that I also use when I have some leaders that get stuck, and they're not using systems-based thinking. They're using sort of what matters in my department, and this is why I need it, but not understanding the context, which is a larger context. So that slide, you could actually substitute some of those areas for leadership skills also, and it would be sort of understood that way. I just wanted to make that comment, and people, I think, also the understanding of how the organization works, I think, is really important. As you start designing a project, I think, because that way, then you can work effectively and proactively to see if how to implement it, what are the circles of the areas of power in the organization that you need to influence, and then find ways of having effectiveness and sustainability.
Exactly. And the learning health system is top down and bottom up. So you have to have ideas from those who are providing the services directly. But if you don't have policies in place, if you don't have help, if you don't have occasional funding, it's hard to move the needle.
Okay. That leads me also to the other slide that you said about the push and the pull. And I think sometimes leaders, and I can certainly be responsible for this. Sometimes that slide sort of helped explain that the pull sometimes works more effectively than the push instead of being told what to do. And how do we as leaders sort of like prevent that from happening, or what strategies would you suggest that leaders and organizations use to effectively influence, but not pushing to the extent that the organization will not respond?
I think that in many ways is one of the goals of things like the Shark Tanks, sort of a way to be able to identify what's going on and what are the needs out across the whole organization. So an organization as big as the VA, as big as Parkland, as big as UT Southwestern, the leader can't know every single thing that's happening. So working to sort of have those bubble up, I think that's been extremely helpful. And most people don't, maybe they may not know either how to get to the leader, or they may not feel as comfortable just because it's, go to the main office and you sort of see that. So I think having things in place so you can very deliberately get those ideas to bubble up is one of the effective ways.
Okay. And then the other comment that I wanted to make from the hand washing project to the others, there was a component of education and teaching, and I just wanted to see if you could comment on that. We often think that that's one of the weakest things that are implemented or that can really lead to lasting change. But in your world, is there any evidence that that is the case? And how do we enhance then education and teaching to make it sustainable?
I think it's one of those things that's necessary but not sufficient. So if we don't have sort of the basic knowledge base, and sometimes we make assumptions about the knowledge base of folks that may not be accurate. But so I think that becomes necessary. I do think that working with people who are experts in educational programming and hands-on learning and that sort of area that can help sort of cement that is really important. But then it's following up. It may be the audit and feedback. It may be the clinical decision support. It may be the putting navigators into a program. So we did a lot of the early work on lung cancer screening, for instance, and found that we needed the extra help of navigators. So we had to start with making sure that our clinicians knew about the new information on lung cancer screening. This was sort of early on in that time, but they couldn't just respond to the knowledge. They had to have some help as well.
Okay. So I want to wrap up with two concepts of high reliability. Clearly, your comments just a few minutes ago, reluctance to simplify, and certainly deference to expertise, and bringing some of the experts to help the clinicians navigate the problems, and then navigate and design a system that is sustainable, for change. So thank you so much, Dr. Jackson. We learned a lot. I really appreciate everybody's attention and everybody's work. We will ask you to please do an evaluation and put some comments and give us some feedback about future topics for discussion. And we look forward to collaborating with you, sir, and welcome you to the Medical Sciences Campus. Thank you so much.
Thank you all. It's wonderful to talk to you.